Hello, Audio Medical Basics. This guy, this book, case files, emergency medicine, and case number 11, rabies, animal bite. And we'll start with reading the long case. A 15-year-old boy was cleaning some items in the shed in his backyard when he saw a bat. The bat bit the boy on his dominant hand, after which the teenager ran into the house. His parents brought the boy to the emergency department in your hospital. His vital signs on arrival were a blood pressure of 115/70 millimeter mercury, heart rate of 105 beats per minute, respiratory rate of 14 breaths per minute, pulse oximetry of 99% on room air, and a temperature of 37.1 degrees centigrade, equals to 98.9 degrees Fahrenheit, if you are wondering. Inspection of the wound shows deep bite marks with a laceration close to the proximal interphalyngeal joint. The bat escaped after the boy was bitten, and the bat was not found. So, first question, what is the most likely diagnosis? Second question, what is the next step in treatment in this patient? So, summary of the case. A teenage boy complains of a deep bite to his dominant hand by a bat. This bat was acting strangely. The bite is fresh and the bat cannot be located. So what is the most likely diagnosis? The most likely diagnosis, unprovoked attack by a rabies infected bat. Best initial treatment, notify animal control to locate the animal, then clean the wound and administer both passive and active rabies immunization to the patient. Administer tetanus toxoid if not received within the last 5 years. Okay, considerations in this case. This 15-year-old teenager encountered a bat exhibiting abnormal behavior. The bat, normally a nocturnal animal, is active in the afternoon in this case. This is suspicious for a rabies-infected bat. Other important considerations in this case are that the patient was bit near a joint space. He was bitten near a joint space, the patient's tetanus status, and the possibility of retained teeth. All these are important considerations in this case. In this patient's case, post-exposure prophylaxis for rabies and delayed primary closure to observe for infection are reasonable. Post-exposure prophylaxis for rabies should include a combination of immediate passive immunization and active immunization. Passive immunization being rabies immunoglobulin and active immunization being human diploid cell vaccine. Tetanus vaccine should be administered if the patient has not received it within the past 5 years. So definitions, important definitions in this case. Hydrophobia. What is hydrophobia? Hydrophobia is the violent contraction of respiratory, diaphragmatic, laryngeal, and pharyngeal muscles initiated by consumption of liquids. And we note here that hydrophobia was the old name for rabies. What is a venom? Venom is a specialized form of saliva that is rich in proteins, polypeptides, peptidases, and nucleases. Its effects can range from paralysis, digestion, or incapacitation to death. Next, we'll go to clinical approach. We'll speak about general bite management. So, general bite management. Good wound care is the mainstay of bite management. A detailed history of the bite, including type of animal, whether provocation occurred, location of bite, and time since the bite, should be followed by a careful physical examination. Physical examination should focus on the patient's neurovascular status, the potential for tendon involvement, any evidence of cellulitis, and the potential for joint space violation. The wound should be irrigated, tetanus booster updated if more than 5 years has elapsed since the last administration, and antibiotics administered if the bite is high risk for infection or already infected. A radiograph should also be obtained to evaluate for a fracture and retained teeth. For bites with potential tendon injury, the involved extremity should be splinted. Simple bites of the trunk and extremities, well, except for the hands and feet. So simple bites of the trunk and extremities, except for hands and feet, less than 6 hours old, can generally be closed primarily. Simple bites of the head and neck area, less than 12 hours old, also can be repaired primarily. However, puncture wounds, bites of the hand or feet, wounds more than 12 hours old, and infected tissues are usually left open. With any bite injury, the appropriate authorities should be notified to find the animal and observe it for abnormal behavior. Prior to arriving to the emergency department, any open wound or bite should be thoroughly washed with soap and water. In the emergency department, irrigation of the wound with saline removes debris and lowers bacterial counts. There is no added benefit to the addition of hydrogen peroxide or povidone iodine to the irrigant. Any foreign body or devitalized tissue should be removed. The clenched fist injury, also called a fight bite, is especially important to assess because a small bite injury may deeply embed bacteria into the joint spaces or tendon sheaths of the hand. This can lead to a serious infection. A radiograph to assess for fracture or foreign body should be performed. The wound should be irrigated, the tendons examined, and antibiotics administered. In cases of delayed evaluation, look for signs of infection including cellulitis, abscess formation, or tenosynovitis. Due to the high risk of infection, these cases typically require admission to the hospital for IV antibiotics or surgery. Next, we'll talk about bacterial infections. Dogs, cats, and humans account for almost all mammalian bite injuries. Oral flora in dogs and cats include Staphylococcus aureus, Pasteurella species, Capnocytophaga canemorsus, Streptococcus, and oral anaerobes. Humans usually have mixed flora, including Strep aureus, Haemophilus influenza, Eikenella corrodens, Eikenella corrodens, and beta-lactamase positive oral anaerobes. In cat bite wound infections, Pasteurella multocida is the most commonly isolated bacteria. Human bite infections are typically polymicrobial. Good initial choice antibiotics include amoxicillin with clavulanic acid, ticarcillin, clavulanic acid, ampicillin, sulbactam, or a second generation cephalosporin. Duration of administration for established infections is 10 to 14 days and 3 to 5 days for prophylaxis. Failed outpatient treatment of wound infections is an indication for admission and IV antibiotics. Next, we'll talk about rabies. Rabies is a single-stranded RNA rhabdovirus that attacks the central nervous system, causing an encephalomyelitis that is almost always fatal. It has a variable incubation period, averaging 1 to 2 months, but may be as short as 7 days or as long as 1 year. Clinical presentation begins with 1 to 4 day prodrome with fever, headache, malaise, nausea, emesis, and a productive cough. An encephalic stage follows with hyperactivity, excitation, agitation, and confusion. Brain stem dysfunction follows with cranial nerve involvement, excessive salivation, followed by coma and respiratory failure. Hydrophobia, which is the violent contraction of respiratory, diaphragmatic, laryngeal, and pharyngeal muscles initiated by consumption of liquids. This hydrophobia is a late sign of infection. A bite is the most common means of transmission of rabies. Although animal vaccination programs have decreased the incidence of rabies, they have not completely eliminated it. They have not completely eliminated it. Risk factors for transmission include unprovoked attacks, unknown or unobserved animals, or animals displaying unusual behavior. Animals with increased lacrimation, salivation, dilated irregular pupils, unusual behavior, or hydrophobia are particularly suspected. Bites to the face or hands confer the highest risk of rabies transmission, but any breakage of the skin can transmit the virus. Worldwide, in locations with incomplete animal vaccination, dogs are the most frequent vector for rabies transmission to humans. In the United States, dogs are largely rabies-free. Healthy dogs, cats, or ferrets that bite humans should be confined and observed for at least 10 days for signs of illness. Next, we'll talk about rabies prophylaxis. A thorough history and physical examination in the context of the geographical location will give important clues for treatment. Identification of the animal and observation will help guide treatment. Pre-exposure prophylaxis with active vaccination may be given to individuals at risk, like animal trainers, animal control field workers, etc. This does not obviate the need for post-exposure prophylaxis. Post-exposure prophylaxis is indicated for any person possibly exposed to rabid animal. Post-exposure prophylaxis is a medical urgency, not an emergency, but time is essential. Rabies immunoglobulin can give a rapid passive immunity that will last for 2 to 3 weeks. Passive immunization with human rabies immunoglobulin, 20 international units per kilogram, should be injected around the wound site as soon as possible. Active immunization should then be given intramuscularly with a different syringe at a different site. The active vaccinations include human diploid cell vaccine, HDCV, purified chick embryo cell vaccine, PCEC, or rabies vaccine adsorbed, RVA, and should be administered on days 0, 3, 7, and 14 and day number 28. Active immunization will lead to antibody formation in about 1 week and should last for several years. Next, we'll read about snake bites. Venomous snakes are found throughout the United States except in Maine, Alaska, and Hawaii. There are two main families of venomous species, the Crotalinae and the Elapidae. The Crotalinae, also called pit vipers because of the presence of a pit-like depression on their face, include rattlesnakes, copperheads, and water moccasins. The Elapidae includes the coral snakes. The Elapidae includes the coral snakes. Not every snake bite results in the release of venom into the victim. Dry bites occur up to 20% of the time. When venom is injected, it usually occurs in subcutaneous tissue and is absorbed via the lymphatic and venous system. Clinical manifestations of envenomation will vary depending on the toxin, depth of envenomation, location of the bite, and size and underlying health of the victim. Pit viper envenomation ranges from minor local swelling and discomfort at the injection site to marked swelling, pain, blisters, bruising, and necrosis at the incision site, and systemic symptoms such as fasciculations, hypotension, and severe coagulopathy. In contrast, elapide envenomation usually begins as minor pain at the incision with a delayed serious systemic reaction that may lead to respiratory distress secondary to neuromuscular weakness. The primary objectives in snakebite management are to determine if envenomation occurred, to provide supportive therapy, to treat the local and systemic effects of envenomation, and to limit tissue loss and disability. If the species can be identified, the appropriate antivenin can be administered if required. Treatment of envenomation is also varied. If it is a dry bite, general wound care is usually sufficient. Radiographs should be performed to evaluate for retained teeth. Signs of envenomation can be broadly classified into either hematologic or neurologic. Hematological effects of envenomation include disseminated intravascular coagulopathy, ecchymosis, and bleeding disorders. If there are signs of envenomation, then laboratory studies, including but not limited to clotting studies, liver enzymes, complete blood counts with platelets are necessary. Giving blood products to an envenomated patient with a coagulopathy will not correct the problem. The circulating venom responsible for the coagulopathy is still present and will likely inactivate the blood products. Therefore, the mainstay in treatment in venom-induced coagulopathy is antivenin, preferably type-specific, not blood products. Nonetheless, if the patient is bleeding, it is prudent to administer both antivenom and blood products. The most commonly available antivenom for treatment of North American crotalid envenomations is Crotalidae, polyvalent immune fab crofab. Surgical debridement or fasciotomy in the setting of envenomation should not be done, as this may lead to further bleeding. We spoke about the hematological effects of envenomation, and now we'll speak of the neurological effects of envenomation. The neurologic effects includes weakness, paresthesia, paralysis, confusion, and respiratory depression. Asymptomatic patients who were bit by a pit viper should be observed for 8 to 12 hours after the bite. This should be extended to 24 hours for coral snake bites because of the absence of early symptoms. The local poison control center should be contacted early in all symptomatic snake bites and will be able to help with management and location of antivenom. And there is a number provided for those who live in the USA for Poison Control Center. Finally, we read the clinical pearls. In the United States, rabies transmission by dogs is nearly zero, whereas transmission by bats is more often seen. Worldwide, dog transmission is still common. Rabies prophylaxis is indicated for uncaught wild animals and animals that start behaving abnormally. Bites that are more than 6 hours old are, in general, left open because of the risk of infection. Snake bites should be treated like other bites with special attention paid to species identification and rapid administration of antivenom if required. All right, thank you very much for listening for this case file from the emergency medicine book about the animal bites, rabies in particular. And this will be the first case of the emergency medicine case files, and we have 2 more cases to do. Thank you very much for watching, if you watched, and please do comment, do like, and do subscribe. And it's important to tell you at this point of the of these videos that this here is actually a toilet paper. It is not designed for radioactive material, but I think it would be helpful in case of a nuclear. I think it would be helpful if you have it's something that is that have some radiation in it, and you go to the toilet and you have this some irradiated poop. So I think if you wash the irradiated poop with this particular roll of toilet paper, it will not do any benefit for you, but I think it will make your poop radiation free. So I think your poop will live happily in the toilets, will live happily in the sewers until it disintegrates. So I think if you care about the health of your poop, you should wash yourself. You should wipe yourself after pooping with this particular radioactive zone toilet paper. Thank you very much for watching. See you on next video. Please take care.